Hello, everyone. Thanks for joining. So this is going to be a quick introductory session to neuro-ophthalmology. We're going to sort of talk about the things to consider and where our future sessions will kind of go in terms of pathology. So just as a background to it, it's always really worth taking a step back and reminding yourself of the anatomy in terms of what happens with the visual pathway. So things are already complicated when they're in the eye itself, and they just get more complicated really the further back you go. So it starts with the optic nerve to the optic chiasm, and usually this sort of is up to where people understand things really, really well. And then what happens afterwards starts to turn into a bit of a myth with your optic tracts and your LGN, then the radiations. And then, I mean, when things get to your visual cortex, things actually get really complicated in terms of how they present clinically with your patients and what can go wrong. You then obviously also have the sort of ocular motor system with the third, fourth, and sixth nerves. And again, taking a moment to remind yourself where they run, where they leave, the brainstem, and how they come forward to the eye, and which muscles they innervate, and therefore what can go wrong. And both in neuro-ophthalmology and in strabismus, we'll sort of go through different ocular motor disorders. But in neuro-ophthalmology, this tends to present either in the kind of emergency sort of setting with things like third nerve palsies or more sort of chronically and joint diseases as well. So when you're approaching the patient, taking a really full, thorough history is really helpful. Taking a very close look at their eyes, making sure that you're not missing any sort of ocular pathology that could be explaining what's going on, and have a sort of good system to go through in terms of what you're considering as far as your differentials go. And then also just try to be a bit deliberate with your investigations. It's really easy to sort of send a massive net of different investigations, but sometimes over investigating the patient can be, you know, less helpful actually than actually just being a bit more direct with what neuroimaging you want, with what bloods you want, and taking a more systematic approach to investigating your patient. So starting with the history, neuro-ophthalmology conditions, especially with things like optic atrophy, neuritis, neuropathies, it's really important to get a really good understanding of the symptoms and when they started and how severe they are and what exactly the symptoms are. So, what kind of vision loss do they have? Is it a complete blackout? Do they have a sort of kaleidoscope or distortion of symptoms of vision? Do they have a field problem? When did it start? Did it start really suddenly? Is it sort of a subacute onset over a matter of days, or has it been over several months? And how severe is the vision loss? Have they dropped right down to hand movements, or is it something that sits in the realm of about 618, 630? And do they have any associated symptoms? Do they have any problems with ocular motility? Do they have any pain? Are they having any problems in terms of any redness to the eye, for example? And then the systemic history is also really important. So have they had any recent history of trauma? Do they have any medical problems? Any deficiencies that we know about? Are they on any drugs that are associated with optic neuropathies? And have they had any surgeries either to the head or any sort of major surgery recently with major blood loss? Just take a really good, thorough history of these patients, especially if you're in the context of a neuro clinic, because sometimes you'll find something that actually may explain what's going on, but was missed on in a sort of initial casualty presentation. Then with the examination, again, you want a really full front to back exam. So looking at the eye movements, are any of the nerves involved? Looking at the pupils, assessing that optic nerve, taking a full ocular exam to actually look at the different layers of the eye, and then also taking a close look at that nerve head. Is there any signs of any previous atrophy, any previous optic neuritis? Do they have a temporal pallor, for example? Are the borders of the mar of the are the margins of the disc really clear? What's their RNFL doing? And then you also want to consider maybe looking at the rest of their cranial nerves, maybe trying to locate a lesion in the head, and also just doing a very general gross motor assessment and a sensory assessment of the patient to see whether or not there's anything else that could explain systemically what could be going on in front of you. There's lots of investigations to hand. You've got things like, your the usual that you'll come across, your OCTs, your FFAs. I've there's a few kind of tutorials now under the investigations playlist looking at OCTs and FFAs and EDTs. You can also sometimes actually track someone's nystagmus, for example, and this is a picture of what can you can sort of get in terms of tracking the eye movements of the left and right eyes. And you can do that in 9 positions of gaze, looking at a screen and trying to characterize the kind of nystagmus you're looking at. And then also neuroimaging, and there'll also be some sessions looking specifically at CTs and MRIs, what you might come across and what you might want to order for the patients as well. But neuroimaging can be really helpful when assessing the optic nerve itself and actually also the entire visual pathway. And this is just a quick snapshot of what can go wrong, just to end with. So you've got problems with the nerve, looking at optic atrophy, neuritis, neuropathies. You could have problems at the chiasm with growth. So, for example, issues associated with oculocutaneous albinism. And then you have the retrochiasmal disorders, problems with the optic tracts, problem with the optic radiations. And then you also have motor disorders, so either problems with the third, fourth, and sixth nerves themselves, or potentially supranuclear disorders, maybe some sort of gaze palsy, skew deviations, nystagmus as well, both from sort of physiological infantile nystagmus and then acquired nystagmus as well, and then ocular myopathies, things like myasthenia gravis, myotonic dystrophies. So there's all sorts of things that can go wrong, and there's also some miscellaneous disorders as well. And over time, we'll sort of touch on the different kind of pathologies that you can come across in neuro-ophthalmology. But some of these things also have a lot of overlap. So, one problem may present with both motor disorders and issues with the optic nerve. So bringing everything together and putting all those puzzle pieces together to actually figure out what exactly is going on is really a big part of what happens in neuro-ophthalmology, where there's a lot of time taken in trying to actually get the diagnosis, because the management, a lot of it overlaps. Some of it is very conservative. There's not a lot of treatment for some of these disorders, and a lot of it is sort of monitoring and counseling the patient. So taking that time to get the diagnosis right can be really essential. So just to summarize then, always take a very careful approach to neuro-ophthalmology patients. A lot of the pathologies overlap, and it's always worth sort of taking a step back and actually figuring out exactly what's wrong with the patient, looking at your blood results, looking at your imaging, when you're considering a very kind of what is a very vast range of pathologies. And a lot of them are to do with systemic disease. So having a good understanding of neurology and neuroanatomy is really, really helpful. And then also in terms of your clinical experience, taking actual time to explain these diagnoses to the patients can be really helpful, because a lot of them are very chronic, a lot of them are progressive, and a lot of them can't be treated. Um, and some of them can sometimes be completely idiopathic and unexplained. And taking a moment to explain to the patient what they can expect and getting them in touch with things like eye care liaison officers, visual aid clinics, and things like that can be really helpful in helping your patients understand what's going on. Because while some of them can be treated, and a lot of them can be, there are some neuro-ophthalmic conditions that are chronic and progressive and untreatable, and taking that time to explain that to the patient can be really helpful to help the patient sort of absorb what's going on. So that just brings us to the end. It's a very, very quick introduction to neuro-ophthalmology, and the sessions will sort of, I plan to sort of go through things in quite granular detail. So I won't sort of, I'll try and break things up, you know, quite a lot, to make things a bit more absorbable. Because I always found when I came to learning neuro-ophthalmology, especially for exams and clinical practice, things can be really difficult to actually understand what they are and how they interact and where the overlap is. And there is a lot of overlap in neuro-ophthalmology. And once you start to see things more of a spectrum of disorders, I think things start to click into place, and that will be the aim of our future sessions. So thank you very much for joining. Um, this was just an introductory session, but please do remember, for any future sessions, the feedback link is always in the description. So thanks very much for joining, and we'll see you at the future sessions.